So we will start recording this
أنت
session
نش
now.
إذا بتعملي معروف وطي صوتك عم بسمعوا لبرا هون وحد.
So we will start recording, and our first, not really presentation, but just an introduction to the Nutrition Information Systems Working Group, what it is, what we have done so far. It's basically just a short 5-minute sort of intro. So I'm just going to ask Louise to tell us a little bit about the Nutrition Information Systems Working Group.
Okay, thanks Hassan. So just a very brief basic overview of the Nutrition Information Systems Working Group. We are one of the technical working groups under the GNC Technical Alliance. And the focus of our working group is obviously to provide systematic and coordinated technical guidance and support to issues related to nutrition information systems. Some of the work that we have been doing it's a wide range, obviously looking at providing kind of some immediate support that's required. And this was shown quite a bit last year when we all were faced with the issues around the pandemic. It also focuses on emerging humanitarian situations and contexts that require for us to think a little bit differently around NIS and give some immediate adaptations or some immediate solutions to countries. So that's one piece. But in addition to that, we also look at development of technical guidance and try to address some of the technical issues that colleagues face, consistently over a period of time. So within this group, we have a good representation of experts. We have UN agencies. I don't want to risk mentioning some and then leaving out others, but we have we do have the UN agencies on board. We also have representation from NGOs that are experts in nutrition data and information. We also have some colleagues from other institutions. So for example, we are supported by CDC that give us a lot of technical expertise on nutrition information and epidemiology, which is useful. That said, also, as needed, we do reach out if we have to through our different partnerships and linkages with other experts as needed to ensure that we are able to provide the technical support and guidance that is required. We meet monthly, and we also have a system or structure in which we get feedback from colleagues in the field. So that's a quick overview. Obviously, the main purpose of the work that we do is to ensure that we do have nutrition information systems, especially in fragile contexts, that are responsive to the needs and that are able to provide the required data and information for decision making. Thanks, Hassan. Back to you.
Thank you. Thank you very much, Louise, for that very, very clear introduction of the NIS Working Group. So we are going to go into our first presentation for the day. This is a presentation from our colleagues in Bangladesh, Alon and the colleagues who are working in Bangladesh, presenting the adaptations to smart surveys in the context of COVID-19. So their experiences, how they basically adapted some of, what measures they took in terms of resuming surveys in Bangladesh. So welcome.
Thank you, Hassan, and welcome everyone. My name is Lalon. I'm working as surveillance head of department for Action Against Hunger Bangladesh. And I also work for nutrition sector advisor and chairperson for assessment and information management technical working group. Today, I would like to present our experience and key lessons learned, followed by smart survey conducted during the COVID-19 situation. So just to highlight some background to information, like we did the smart survey in Cox's Bazar, which is highly disaster prone coastal district of Bangladesh that inhabits more than 800,000 refugee population across the makeshift and registered camp. And since the influx of refugees in 2017, nutrition sector has been providing comprehensive services and regularly monitored the health and nutrition situation under the leadership of Action Against Hunger Bangladesh. So however, due to COVID-19, the nutrition programming, including nutrition service, has been disrupted, where we had to postpone all kinds of population representative surveys in the country. However, after releasing new operational guideline in October, Action Against Hunger piloted the implement interim guideline in the refugee camp as a first country to implement this smart survey during the context of COVID-19. And the guideline was very useful and guide us, but we also had to make some adaptations for the smooth running of those survey. So through this presentation, we would like to capture our experience and operational adaptation while implementing those interim guidelines on resuming smart survey, as well as to document and disseminate our key lessons learned and recommendation to further support the improvement of interim guidelines, and that will help to implement in other countries during the COVID-19 pandemic situation. So we made necessary programmatic and technical and operational adaptation during the survey. At the planning stage, we usually monitor the COVID-19 situation and discussion with relevant authorities and assessment technical working group and expert at ACF Smart Team at Canada and France SPU, and to get the necessary approval and ensure the context is suitable for conducting a smart survey. After that, we also sensitize the community prior data collection to avoid confusion, misinformation, rumors, and fear due to COVID-19 that allow us to ensure maximum participation and cooperation during data collection. We also reduce the number of indicators to minimize the time spent in households so that we can able to decrease the contamination risks. We also minimize the sample size by adjusting precision level during sample size calculation that will allow us to reduce data collection duration. At the same time, we used higher non-responder rate to account for possible refusal and systematic refusal due to the exclusion of COVID-19 issue. So we also made some adaptation related to human resource, like we used experienced staff who conducted multiple smart survey in ACF and who passed standardization test. So that will allow us to shorten the overall duration of the time, and it will allow us to skip the standardization test. We also included a special IPC training during the training session to ensure that team have good understanding about the health and safety measures, and they can able to implement those procedures in the field level. And we also considered minimum staff per team to limit the exposure and allow physical distancing. In addition, we also keep reserve team to recall at any time if a team member showed COVID-19 sign symptom, so that we can replace the team And throughout the implementation, we closely monitored the health situation through the health screening checklist, and every team members were tested for COVID-19 before starting the survey. And we also ensured we have adequate fund to procure necessary PPE, personal protective equipments for the survey team. During the field implementation, so we also consider the some exclusion criteria. So we excluded the household and children who are at risk with COVID-19 to limit the cross-contamination between household and for the survey team. We also use the digital platform for data collection and day-to-day feedback sessions that will allow us to reduce data entry time and unwanted physical contact. And we also strictly follow the IPC measures for the safety of the community as well as for the survey team. And based on those adaptations, we find some critical issues, like for non-responder rate, that was finally encountered very low, 5.4 to 8.3% compared to our assumption at planning stage that we assume 12 to 8%, because we considered the COVID-19 issue like related to high fever, that those households were excluded. But finally, the COVID-19 related issue, the exclusion criteria was very low. It was 1.5%. And we also experienced that additional 3 to 5 minutes required per household to allow for the implementation of IPC health and safety measures. And overall, with those adaptations, the overall data quality as per plausibility checks and for SMART, it was excellent. And for those adaptations, we have some key lessons learned, like it is very important to evaluate the situation of COVID-19, the risks and benefit before conducting any kind of survey during the COVID-19 situation. And it needs local or national level consensus from the health authority or government authority. And evaluating the community perception is also crucial to understand the local context and perception around the COVID-19 to avoid stigma, fear, or misconception. And having experienced staff in the team is also important to understand the local context. And considering the child exclusion due to fever might have potential bias due to COVID-19 or morbidity, or if the morbidity is higher related to fever is higher, because we know if we consider the exclusion criteria related to fever, it might have some bias in the estimation of malnutrition. Usually the malnourished the children who are with high fever are born to be malnourished. So use of both hand gloves and sanitizer as recommended by interim guidelines was also time consuming and resource intensive, and it may also create extra burden for the team for the waste management. Therefore, we usually use hand sanitizer for the all survey team, but the person who is cleaning the equipment use hand gloves to avoid skin contact for during the disinfection. So another point, the use of standard face masks was very difficult for all children, especially children under 5. Therefore, we offered face mask to all children greater or equal 2 years. And regarding the survey time, SMART guideline usually allocated and recommend for 15 minutes, but it is quite difficult. So a minimum 20 to 25 minutes required on average per household to complete our key indicators like anthropometry and mortality, including applying the IPC measures. And based on those adaptation and lessons learned, from our side, we recommend some of the points that can be considered for further improvement of the interim guidelines, and it can be a way forward for other countries who want to implement the survey. So first one is the country who is going to starting the survey, they need to get approval from the relevant authorities. And another point is to sensitize the local community prior data collection. And then we always need to prioritize the local in-country expertise for technical and survey management. So another point is carefully adapt and contextualize the interim global guidance. And as much as possible, we need to exclude the non-essential indicators and estimate the non-responder rate very carefully for sample size calculation. And we should not directly use the child fever prevalence based on 2 weeks recall period for the COVID-19 related non-responder rate during sample size calculation. We also need to include a special training session on IPC during the training session. And we should also allocate adequate funds, PPEs, vehicles for the survey team. And this is my last slide. So we also need to allocate adequate time for the households so that they can able to complete the questionnaire smoothly, allow them to maintain the strict IPC procedure. And we also need to monitor the field work and IPC measures followed by the team. And in addition to that, we need to consider additional reserve day to revisit all missed household or excluded household, either due to high fever or absenteeism. And we always need to keep 1 or 2 reserve team on standby so that if any team got infected, then we can replace them. So this is all about my presentation. Thank you.
Thank you very much, Lalon, for that. And thanks for really sticking to the time. So I'm just going to ask that colleagues, if you have any questions, please feel free to put them on the chat box. We'll allocate some time probably towards the end to sort of address some of the questions. But for the moment, I would like to invite now our next presenter, Douglas from the IPC, to present on the IPC acute malnutrition roadmap.
Thanks, Hassan. Hi, everyone. I hope you can hear me.
Yes, we can.
Okay, thanks. So I'm going to talk about the IPC acute malnutrition roadmap. I'll start with a little bit of a background and then talk about where we are, what it means, how we came up with this. Okay. So basically, IPC acute malnutrition is a classification scale. It comes with a set of protocols to classify areas based on the severity of acute malnutrition. It also identifies the major contributing factors to acute malnutrition and then provide recommendations to address acute malnutrition by consolidating wide-ranging evidence on acute malnutrition and contributing factors. It was developed under the IPC partnership back in 2016 and was updated in 2019 as we were updating the overall IPC protocols, including food security and acute malnutrition. And as of 2020, it was implemented in about 10 countries. In 2020, GNC came up with the nutrition situation analysis guidelines. And according to the GNC nutrition situation analysis guidelines, IPC AMN, as we call it, is the preferred methodology for conducting nutrition situation analysis in countries where acute malnutrition is of concern. So after 4 years of implementation, the nutrition partners within the IPC partnership decided to take stock of where we are and how we can expand this to other countries beyond these 10 countries where we are implementing at the moment, right? So this consultation took place in May 2021, and what I'm going to present is the result of main results or the key agreements based on this consultation. So the objective of this presentation is to present the key components of the IPC AMN roadmap, focusing on 2021 and 2022, and also share the some key activities and areas of work that are underway or that has been agreed to that we have agreed to work on to expand the IPC acute malnutrition analysis in to other countries, and then also more importantly engage the GNC partners in the rollout of the IPC AMN roadmap. So I'll start with the IPC vision. You know, for those of you who may not be familiar with the IPC, IPC is a classification of both food security and acute malnutrition. Food security, there are two different scales, one for chronic food insecurity and another for acute food insecurity. And then we also have the IPC acute malnutrition scale. So overall vision for IPC is to systematically inform improved food security and nutrition funding, policy and programming decisions to make at levels appropriate to the needs in all countries of concern, right? And then when you come to the IPC acute malnutrition, it is a consensus-based nutrition situation analysis that informs response analysis and multi-sectorial programming, focusing on reducing acute malnutrition levels. So this is kind of the overall vision and the IPC aim and purpose. IPC acute malnutrition is conducted primarily to inform the HNO, humanitarian needs overview, but because it is a situation analysis tool, it can be also used in any context where acute malnutrition is of concern for programming, right? And then it provides three things basically. One is a classification of areas based on the severity of acute malnutrition. So this is for the prioritization exercise. And then it also provides the magnitude of the problem, right? So mainly for providing the people in need or the PIN, right? Finally, it also provides it categorizes the different factors as major contributing factors, minor contributing factors, or not a contributing factors, so that programming can be focused on those major contributing factors to reduce acute malnutrition level. Acute malnutrition also provides not just the current classification or where we are now, but also it provides the projection analysis. So how we are likely to move, how the acute malnutrition is likely to evolve in the next few months or the next season, right? And within the humanitarian program cycle, acute malnutrition results are currently used by different stakeholders. Because it is a situation analysis, as I mentioned, it informs the response analysis, and then from the response analysis you will know what exactly what programs need to be implemented, right? IPC acute malnutrition results are comparable across different countries, different regions, different administrative units within the country, and also then you can compare between countries, different regions, and also at the global level. So the main issue is that we need to make sure that if we are planning to do an IPC acute malnutrition analysis, it fits within the wider humanitarian program cycle, so that it's part of the overall humanitarian response process, right? So ideally, it should be done between September to October, so that it can inform the HNO process, and HNO can then inform the HRP and so on, right? IPC acute malnutrition can also be used to see how the relationship between acute malnutrition and acute food insecurity are in a given context. As I said before, IPC has both acute food insecurity scale and acute malnutrition scale. So when you implement them together, sometimes acute food insecurity is very high, but acute malnutrition is very low. Sometimes it's the other way around. Sometimes they are comparable, right? So it can not only inform about the nutrition situation, but also can be used to compare why is the food security situation is more severe compared to acute malnutrition, for example, right? So that's we as part of the roadmap process, we went through this vision and the purpose, and we redefined what we want, or what IPC acute malnutrition should be informing. Yeah, and then the roadmap focused on mainly 3 areas, right? One about the data availability and access to conduct the analysis, because data was, during the implementation, one of the lessons learned was that data was the major limiting factor when it comes to the coverage of this IPC acute malnutrition analysis. So our roadmap consultation process focused on the data, and specifically about how do we generate data at the right time, and also at the right level. Sometimes the data is generated at the admin level 2, but we want to look at how the situation is like at the admin level 3. So how do we use this, how we can maximize the use of the data collected at the admin level 2 to inform admin level 3 programming, right? So that's one. And the second is about the analysis. So in terms of the analysis, we looked at the capacity that's available to conduct the analysis, and then the quality of the analysis, and also the linkages between food security and nutrition if they are done at the same level, right? And then how do we expand to new countries also was part of this discussion. Finally, about the communication and access to information. So currently we, as I said, we have both these scales, food security and nutrition. Food security results are informing the food security part of the HNO, HRP, and the nutrition part is nutrition analysis is informing nutrition, HNO, and nutrition HRP. But then, there is also this relationship between food security and nutrition. So, and how do we communicate this both at the technical level and also at the advocacy level, right? So these are three main things that we looked at. Linking to all these three, or cross-cutting to all of these three, are the technical development. So each of these components have a technical development element. So for example, if you are going to maximize the use of data collected at the higher admin level to at a lower level, what things can we do besides implementing surveys at the lower level, right? Are there ways to use the data collected at the higher level to inform programming at the low level, right? So that's one example. So technical development is cross-cutting. It's part of all the three pillars of this roadmap. And then we also discussed about the countries where we want to focus. If we want to expand, we can't expand everywhere. So how do we want to organize ourselves and focus on the key countries. So we use 3 criteria. One is we looked at what are the HNO countries at the moment, and we came up with 33 countries. And but there are 33 countries implementing HNO, HRP. And then we looked at within these 33 countries, which are the countries where acute malnutrition is a problem, right? And then we looked at that. And finally, IPC as an initiative has its own priority also, priority countries. So, we also looked at what are the IPC priority countries for 2021 and 23. So in the middle of this Venn diagram is where we have the list of 10 countries that meet all these criteria. So obviously our focus will be on these countries for expansion. But then there are also other countries outside this this middle where we have that have been identified as very relevant and important to expand. So we'll be focusing on that. So just so you know, there is this legend, and with the color coding, if it is a green, we are regularly implementing IPC acute malnutrition in these countries, or we have a plan to implement these countries, AMN in these countries. If it is a purple country, we have done IPC acute malnutrition analysis, but it's very infrequent, mostly because of data challenges in those countries. The ones that are highlighted in yellow are the new ones that even before the consultation started, we identified as countries to move to. And then we have the gray, which is we need to that's the focus for 2021 and 2022. And then the red ones are, at the country level, acute malnutrition may be not a problem, but at the admin level 2 or admin level 3, or in some regions within the country, acute malnutrition may be a problem, right? So it may be relevant in those contexts to focus on those specific areas when it comes to acute malnutrition analysis, right? So yes, so these are kind of the priority countries that were agreed at during the consultation. But we also agreed that if we are already in a country, we are already implementing AMN in a country, we will continue that. We don't want to, even if it is not within this current priority, it is not part of the list of priority countries, we will continue implementing that. For example, Madagascar is not in the not a priority when you apply these 3 criteria, but it is a country of concern. We have been there. We will be. We have been implementing AMN there, so we'll continue in Madagascar in the future as well, right? So that's pretty much it. If you have any questions, we can ask. Thank you, and over to you, Hassan.
Great, thank you very much, Douglas, for that presentation. We really appreciate the insight on the work that's happening within the IPC, especially the IPC acute malnutrition and how it relates to nutrition information systems. So without further ado, I would like to now go to our third and final presentation from our colleague Alessandro, who's a member of the NIS Working Group. Alessandro, over to you.
Thank you. I just found the unmute button. Thanks, Hassan, and thanks to the colleagues. So what I'm going to present is just an overview of a major exercise that was led by Save the Children and IYCF Smart Team Canada on behalf of the NIS and the IFE core group. And the exercise really was a mapping of current practices related to how infant and young child feeding assessments are conducted, are supported in emergency and humanitarian context. The objectives of the exercise, as I said, were basically three, to look into what, as I said, what are the current methods, tools, challenges, indicators, sampling approaches when related to the various IYCF assessments conducted or supported at the emergency level, at the emergency context. Also to try to understand in particular the representativeness of those assessments, looking at the sampling methodology applied and used, and eventually to compile a process and come out with a series of concrete recommendations for both working groups, the NIS and the IFE core group. The methodology was quite straightforward. The team developed an Excel sheet with key questions. Those questions, this Excel sheet-based questionnaire was actually reviewed by colleagues across the two working groups, was finalized and uploaded as a SurveyMonkey, widely distributed across the various clusters in coordination mechanisms. And eventually the data, the findings, the responses were processed, analyzed, and a report was submitted, as well as a slide deck with the full set of findings were submitted to both groups by the end of May. What were these main findings? And again, what I'm presenting now are basically some of many more findings of this exercise, but just to give an idea of what is the current status in relation to the implementation, the support of IYCF assessments in emergency context. So a total of 26 countries, respondents from 26 countries participated in the exercise. Majority, as you can see, belong to INGOs. We had a good representation from local organizations as well as from the UN agencies. In relation to time frame, respondents reported that IYCF-related assessments were mainly conducted in the past 3 years, so 3 years before the mapping exercise. So many of these assessments were basically implemented during the COVID-19 pandemic. And we also asked the type of precautions that they have applied, considering again that some of these assessments were conducted during the pandemic period. And as you can see, the most common precaution that was utilized was basically the use of masks for the enumerators and hand sanitizers as well for the enumerators. In terms of methodology used, it's really interesting to see the diverse and the long list of methodologies that respondents suggested using. And highlighting the top three, basically, as you can see, CAP surveys were mainly used. More than 50% of the respondents suggested CAP survey as a methodology used for IYCF-related assessments in emergencies, followed by more qualitative type of exercises, so like focus group discussions. And eventually, as we may all know, IYCF-related assessments are as riders of smart surveys. We also ask about indicators use, and again, just disclosure here, this mapping exercises was conducted and completed before the release of the 2021 UNICEF WHO IYCF indicators that happened around April. So the data here collected are pre-April. So the questions reflects the 2006-2007 indicators. But basically, from what you can see, majority, if not all, basically have been using the more development type of indicators around the core indicators, as well as optional indicators related to IYCF. And very few, only 5, suggested some other indicators that are more linked to emergency, like access to BMS support by non-breastfed infants, or other type of supports for non-breastfed infants, like relactation and wet nursing. We also try to ask questions around the parameters used for the sample size calculation, as well as basic sample unit. As you can see, and this was a very important finding, in general, the prevalence for each indicator is used in estimating the sample size for the assessment. And also, as you can see, there is a very diverse approach to sampling unit, but households is the one that is more commonly used as a sampling unit. In terms of data collection tools, manual questionnaires remains still the most popular. In terms of type of questions and development of the questions to be used, the UNICEF WHO recommended questionnaires are generally the most common used, but there is also quite a percentage of questions that are formulated by the teams, most likely linked to the use of FGDs, for example, as methods. Some of the challenges that were reported by the respondents, and we summarized the top 5, basically the lack of globally recognized thresholds for IYCF indicators. As obviously we have seen, there is not really an harmonized sampling methodology for IYCF assessments, as well as really no standardized methodology for the conduct of IYCF assessments. Methodologies like, standardized methodology like the SMART or SPIC and so on. And again, the respondents highlighted the lack of IYCF indicators that could be included in assessments, or at least the lack of common IYCF indicators based on their perspective. And the usual issue around sample size requirements for IYCF remains an unanswered or unresolved concern, mainly when using smart surveys and that includes IYCF, an IYCF module. In terms of recommendations, there are 7 top recommendations, really for the SMART team, and this was very directed to them, to look at the possibility to develop an IYCF optional module that could enrich the current SMART survey modules. There is a very obviously an important need and an high priority to disseminate the WHO UNICEF 2021 IYCF indicators, but also to have some consensus around some specific IYCF indicators that assessment should or may include. It's very important to start developing a brief guidance on when to use the various sampling methodology and units, and what are the implications when choosing one or the other. And also, we felt it was important to review the experiences and understand what type of recommendation we can provide to countries when planning and implementing IYCF assessments as a whole. No? There was also the strong recommendation that it will be important to have some predefined set of questions that could be used for IYCF specific indicators. So this is linked to the indicators recommendation. Number 6 is a duplicate of a previous recommendation. And the last but not the least is really about thresholds. Now, as we all know, the humanitarian needs analysis tool that was developed by the GNC with the support of NIS does recommend some consensus-driven thresholds. It will be important to review the progress and the experience in using such thresholds and see if this can be recommended as interim when conducting IYCF assessments. And that's all. Thanks to all the agencies listed here. And back to you, Hassan.
Thank you very much, Alessandro, for that presentation. So We do have about 9 minutes to the end of this meeting. I'm just going to prioritize a few questions that were asked on the chat box to get some response from the presenters. So please don't hesitate to keep posting your questions in the chat box. We're keeping track of them, and we'll make sure to respond to them. So just a few key questions before we close. There was a question from a colleague about the presentation from Lalon about the decision to eventually not use the gloves and hand sanitizers only. So Lalon, did you end up just not using gloves and you chose to use hand sanitizers?
Yeah, sure. So usually in the interim guidelines, it was recommended to use both, but after reviewing the context and the weighing about the cost benefit and the waste management, then it was thoroughly discussed in the country within the assessment technical working group, and we also discussed with smart team at Canada, and then we agreed to use the hand sanitizer for the all. So every person before entering the household, they wash their hand using the hand sanitizer, but the exception was only for the Mizarar assistant, who are also provided and used hand gloves for the disinfection or the anthropometric equipment to avoid the skin contact with the solution.
Great, thank you very much, Lalon, for that. And I actually have just been informed that this session was supposed to be 50 minutes, so we are 3 minutes past time. I do promise you that all the questions that have been asked, we have documented them. We will provide a written response to you through the Global Nutrition Cluster as well as the NIS Working Group. So through the Global Nutrition Cluster Technical Alliance, I think there is a platform on the website where all the key questions would be posted and the responses also posted there. So on that note, I would like to maybe welcome back Louise to give us final remarks before we close.
Okay, thanks, Hassan, and thanks to all colleagues for the presentations. Obviously, this is a small piece of what we're doing. So this is a sample of some of the very important work that colleagues are coming together to do around NIS. Just in conclusion, just to say that the NIS Working Group has been working on a couple of priorities, and as you can see, some of them have been presented. We certainly want to make sure that we continue to support the work on adaptations and technical guidance. This is one of the lessons that we've learned. If there's something that we can take away from the pandemic last year, was that we need to be able to have good systems in place. These systems need to exist first before we can be able to actually make adaptations to them. So a lot of the work and a lot of the lessons around ensuring that we have within our NIS systems the basics in order, that we're able to make sure that we have clear planning and prioritization methods in place and processes. And then this will obviously guide us to be able to generate the information that we need and use it in a way that is helpful for us to make decisions. In addition to that, when we look at now the present, as we were saying in the title, we need to be able to learn and build on what is existing. So some of the work that we've learned from, for example, on how to adapt and do surveys is some of the things that we can take into the work that we're doing currently, but also in terms of moving forward. And lastly, which is one of the points, and I know we were to have a presentation on this, but unfortunately, due to some unavoidable circumstances, we couldn't, is how we can leverage technology and innovation looking forward in terms of how we generate, how we analyze, and also how we share existing data and information. Certainly the use of predictive analysis or innovative ways for us to collect data is something that we are looking at. Earlier in the year, we did bring together a group of people who are doing various initiatives on predictive analysis, on modeling, and there is some promising work that colleagues are doing, but it still brings us back to making sure that we at least have the basics in place to collect and generate primary data. So again, these are some of the areas that we'll continue to focus on and look at as we move forward, and at the same time continue to give the technical support to countries as the different needs emerge. So we look forward to continue working with all of you in these key areas, and I think we're very hopeful that in the coming year, for the rest of the year and in the coming days, that there is still much that needs to be done.